Hi, my name is Srinivas Murthy. I'm excited to talk to you about influenza antiviral strategies within REMAP-CAP. I'm in Vancouver, Canada. I'm a critical care and infectious diseases doctor. I primarily practice in pediatrics. So I'm only going to take a few minutes. Randomized evidence for influenza antivirals in hospitalized patients. I would love for there to be any. Unfortunately, there are no fully enrolled prospective randomized trials of one of the most commonly used medications on the planet, oral oseltamivir, for hospitalized influenza patients. And so it is the year 2023. We've been using this medication for decades, and we do not have any randomized evidence for its benefit. And that's the gap that we're aiming to fill. So previously, and over the past couple of years, we've been enrolling patients with suspected or proven influenza to one of no antiviral, 5 days of oseltamivir, or 10 days of oseltamivir. We've got about 200 randomized in that domain thus far, with a primary outcome of 90-day mortality. Over the past year or so, we've amended this domain. This is what's currently active to patients with proven influenza only. Namely, you need to have a positive test, and incorporating a new medication, baloxavir, that's approved most countries around the world for the treatment of less complicated influenza. So the patients will be randomized to one of no antiviral, 5 or 10 days of oseltamivir, and baloxavir, and then baloxavir in combination with 5 or 10 days of oseltamivir. These arms have been added, and patients are beginning to be recruited to these interventions around the world. The inclusion criteria are now patients with confirmed influenza infection, and that confirmation can be with any locally approved diagnostic test, and age greater than 28 days old. And so now we've included children in this domain. The exclusion criteria are more than 96 hours since hospital admission, or more than 48 hours since ICU admission. The original intent of this domain was to focus on community-acquired infections. If you've already received 2 or more doses of oseltamivir, or 1 dose of baloxavir, you're excluded. If there's a clinical decision by the clinical team that they really want to treat with an antiviral, then obviously they won't be eligible to participate. And for the baloxavir-containing interventions, pregnancy is a specific exclusion, given the lack of available data for safety. The baloxavir dosing regimen is as you see it. For adults, it's 40 milligrams on day 1 and 4, plus day 7 if the clinicians think that it's clinically indicated, i.e. the patient's not getting better. The oseltamivir dosing is for adults 75 milligrams twice daily for the duration of which they're randomized to. Children and renal dysfunction, we provide dosing recommendations, although if there are local guidelines that inform that, we aim to be pragmatic and abide by those guidelines. For pediatrics, and one of the novel aspects of this domain is that we are including both kids and adults for a common disease that affects both children and adults. And we're incorporating novel statistical techniques to learn as much as possible about the benefit or harm in children using adult data that's generated during the trial. So hopefully we'll have some child-specific evidence that can inform child-specific practice from this large international platform. And as always, I do always want to emphasize the global and collaborative nature of REMAP-CAP. We have sites on every continent and patients recruited from every continent, and we're excited to continue to engage with the larger community. Thanks.